Many medications require inpatient detox. And the reason for that is that their withdrawal symptoms are just so severe and could potentially lead to death. Approximately 2% of individuals with alcohol use disorder or alcoholism severe actually can die from if they just stop cold turkey on their own. And so our goal is to really help someone go through the detox process so that they're safe, first of all, and they're comfortable. Detox is not supposed to be punishment. And so I'll start with alcohol use disorder or alcoholism. When we're treating that, generally we put someone on two different medications. One is to prevent seizures, so we may put them on what we call anticonvulsants. And I could name some. Gabapentin is a common one. Depakote's another common anticonvulsant that we use because we don't want them to seize. We will also prescribe something called a benzodiazepine. Either Ativan or Librium or Valium are the most common ones depending on someone's medical stability. And we prescribe that generally at fairly high doses and then taper it over 5-7 days, that sort of thing. And the purpose of all that is to bring someone off of alcohol slowly. Meanwhile, when someone's inpatient, the other things we're doing is we're getting constant vital signs. We have a score for alcoholism in particular called seawah. It's the clinical withdrawal scale. And what we're looking at are vital signs and other symptoms such as sweating, nausea, diarrhea. Sounds great, doesn't it? We're trying to prevent those from happening. And so a lower seawah score is better for us because that means we're treating adequately. If the seawah scores are very high, that means our taper of medication isn't adequate. So we really need to adjust it accordingly. And so that's why we continue to get these seawah scores. Again, our number one goal is safety, keeping the vitals safe so there's not too much stress on the heart. And really my other goal is not to have any seizures. So by using those protocols, using an anticonvulsant, using the benzodiazepines, we're able to safely do that. One of the other drugs that we need to put in, patient we need to put in the hospital for detox is benzodiazepines. So ironically, we detox people from benzos with benzos. So if someone is abusing or misusing, say, a medication called Klonopin, then we would probably taper them on a different drug. And again, slowly bring them down, making sure they're not having severe withdrawal symptoms. We can use the same scale that we use for alcohol use disorder, the seawah, and try to safely monitor them. Ironically, when someone's coming off of benzos, you oftentimes don't see a lot of symptoms like you would with alcohol. I think part of that's because it's a longer acting drug, some of them are, than alcohol, which is metabolized quite quickly. And so the first symptom sometimes you might see would be a seizure, which means you've not done your job. You've not done your job well. And so I really want to hospitalize that group of individuals. The next group of individuals I like to hospitalize for detox are folks using opioids, whether it's pills or heroin or whatever. You're not going to die from the opiate withdrawal, but you wish you were dead because it's so intense. And for this one, we have a scoring system called COWS, Clinical Opioid Withdrawal Scale. And similar, it's measuring sweating and blood pressure and nausea and diarrhea and symptoms like that. And again, a high score means you're not doing your job, and the physician's not doing his job well with ordering the proper medications, and a low score means we're containing the withdrawal symptoms. Someone coming off of opiates may not have any symptoms for 24, 48, even 72 hours, depending on which opioid they're coming off of. And so we may not give them any medication until they start showing some elevation in their COWS scores. Normally, we detox opiates with a medication called buprenorphine. The common name is Suboxone. And we like to use that medication along with some other comfort, I call them comfort meds, something maybe for nausea, something for diarrhea, just so our individuals feel okay. I mean, they're gonna feel something, but I want it to be a 2 or 3, not a 10 in severity. And so again, if I'm doing my job, they feel a little nausea, maybe a little diarrhea, but we can control most of that. And that, again, the process is 5-7 days. We struggle here with advanced recovery systems. Some of the insurance carriers do not want to pay for inpatient detox. And our rationale is that if I feel like crap, the chances of me staying in this process of trying to get off of opiates is 0. If I'm an addict, one of my biggest fears is having withdrawal symptoms, because they're painful, they're ugly, everything hurts, you feel nauseous, you have diarrhea like crazy, you're sweating, you have a temperature, and it's like the worst flu you've ever had with total muscle aches on top of it. How do you alleviate that? Well, if you're an opioid addict, you would take an opiate, and then therefore we've not accomplished our goal of outpatient detox. But if I am inpatient, I can control the opiate for 5-7 days, and our patients do really, really well with that. And I think it gives them a chance actually to start the process of recovery once they're detoxed.